All right, our next conversation is about universal health coverage. So on the 20th of, what month was that?
October.
Yeah. Just the other day. There was a national launch of the universal health coverage in the country by the president. And this is, after this long journey of we're going to have UHC launched countrywide. And we know several laws were brought in, several things happened, and the whole conversation about UHC has been taking place for a while. Now, of course, UHC is facilities, UHC is getting access, UHC is getting affordability, UHC is, being able to get health care at your nearest level, okay? Who is giving you that healthcare? Healthcare workers. Do we have proper, well-trained healthcare workers countrywide? That's a conversation we want to see. Okay, we think about doctors, we think about nurses, we think about lab technicians, we think about all the other cadres of healthcare workers. The Kenya medical training colleges countrywide are big. And that's why we are joined now by the CEO of KMTC, Dr. Kelly Oluoch. Good morning, Dr.
Good morning.
Welcome to the hot seat of the Situation Room.
Thank you.
Mambo namna gani?
Mambo salama.
Very good.
Yes.
Karibu sana.
Okay.
The proverb?
Our proverbs for the whole of this week come from the country, the Republic of Congo, otherwise known as the Congo, otherwise known as Congo Brazzaville. Great events may stem from words of no importance.
Great events may stem from words of no importance. Dr. Oluoch, what's your interpretation of this proverb?
Okay, thank you so much. I know that words have power.
Yes.
And I know that every word has a meaning. And as it is, we become what we think about, and what we say, that's what we are, and that's what we become. And so to me, I don't think that whatever we say should be taken casually. Whatever we say, whichever context, has a way of coming into its physical form. And therefore, that's why it's important to use words carefully, because then it means that words then becomes translate into their physical form. Yeah. Yeah.
It's a very, very good interpretation. It's actually a very insightful interpretation.
It's deep.
Yes, it is.
It's deep. Daktari, when CT was growing up, he saw KMTCs. When I was growing up, I saw KMTCs. Now, recently, we have seen KMTCs. Those days used to be few. One maybe in a district, in a larger district.
There's some provinces that had them. There's provinces actually that had them.
Yes. That had KMTCs. Now, there are very many KMTCs. Give us a history of KMTC.
Okay, thank you, Eric. KMTC was started in 1927. 1927. We are having 96 years of experience of training human resources for health. It was started at Jean School, the then Kenya Institute of Administration. It later came to King George IV Hospital,
which is Kenyatta.
Yes, that time it was along Kingsway, the current University Way. And then it moved to the current Kenyatta, that is King John IV Hospital. And there has been a lot of evolution of the institution. At one point in time, it was called College for Health Professionals. That is around 1987. It has grown from 4 students in 1927 to the current 62,807 students. The college has also had a tremendous expansion in terms of the number of campuses. Currently, we have 74 campuses in 44 counties across the country. Eric, I think it's also important to note that this year, the college is going to graduate the highest number of human resources for health, that is close to 23,000 health workers. So as an institution, we want to look at how then do we become relevant to the healthcare needs of the country. How do we support UHC? How do we ensure that quality is inculcated in all our processes and throughput? And then how do we ensure that the graduates eventually get meaningful involvement in terms of economic empowerment, in terms of employment, in terms of contributing to the communities they come from? And that is basically why the institution has developed a strategy that will be a 5-year strategy to look into the quality of training, to look into research, consultancy, and innovation, to look into digital transformation, and to look into sustainability of the institution. And here in sustainability, we want to not only look at financial sustainability of the institution, but the institution being a viable institution, being able to satisfy the needs of its stakeholders and staying relevant to the call of duty of UHC and primary healthcare, and providing solutions that are real time. Like right now, City, I've seen that in your paper, there's a lot of discussion about emergency medical technician. There's a page that is talking about it. So the institution has looked at such cases where the first point of contact means life or death to the person who becomes a victim of accident. And so we have looked at how then do we make sure we have relevant trained personnel. How do we empower other state actors, the police, the border riders? And so we just don't want to be in classroom settings. We want to be relevant to the public, where that knowledge is needed most and where it means life or death of a victim. Yeah.
Who is trained at KMTCs? When we talk about medical professionals, who are the individuals who walk through the doors of these colleges and then who graduate? What do we have then in terms of professionals after graduation?
Okay. Majorly people who train in KMTC, we have 7 faculties. And we have 18 departments, and currently we have 95 courses. And the faculties start from clinical focusing faculties, that is curative services, in which we have clinical medicine, that is faculty of clinical medicine. We have nursing. Then we have pharmaceutical sciences as another faculty. Then we have those rehabilitative sciences, and in rehabilitative sciences we are looking at courses like physiotherapy, occupational therapy, optometry. We're also looking at public health, and here we have community health assistance, public health course. We have community health promoters. We also have short courses for community health extension workers. And we have also what is called the health information systems and medical education. Here we produce graduates who are able to keep records, be able to use them real time to enable other healthcare professionals make decisions concerning people's health, the demographic data, and also be able to produce those who can teach in our faculties, because we derive majorly our faculties from professionals. So you have to turn them into lecturers. So we have a faculty for medical education that enables those who we have recruited to teach for us to be able to be to understand pedagogy and be able to then translate into from professionals into real classroom setup, and also be able to instruct learners in clinical areas and our skills laboratories.
What do they graduate with? Certificates, diplomas, higher national diplomas?
They graduate with certificates. Majority graduate with diplomas. We have higher national diplomas, and then we also have short courses that we offer to enable, strengthen those who are already working to provide services that are relevant and which are up to date. Yes.
So upon graduation then from a KMTC around the country, you will then be able to enter into a workspace whereby these resources then are being delivered by nature of the person who has graduated. So you do not need additional education for a very basic level of service delivery. Is that what we're saying? Or must you then go to yet another institution and then get additional education? Or can you leave a KMTC today and practice and deliver health services as they are needed moving forward?
Yes, Ndu. KMTC offers what is called competency-based curricula. And our mode of learning is 30% theory, that is being in class, learning about the meaning behind the practice. And then we have 70% of the time that students either practice in our skills laboratories or go to clinical area where they then learn on real patients about procedures, interventions, and then that means that by the time our students graduate, they have the capacity to practice in the clinical setup. So they do not need any other training after that to be able to have to interface with the patient, because they will have done sufficiently what is required. What then that means also is there is also KMTC is highly regulated institution. We have almost 10 regulatory bodies that monitor training at Kenya Medical Training College. And so when students graduate, then there's also the other face of it, of being able to practice as a certified practitioner in that area. Like once you graduate with nursing, then you have to sit nursing council exam, and then you get enrolled as a nurse in Kenya to practice. And so what then is needed immediately after you graduate from KMTC is to make sure that regulatory bodies give you authority to practice through sitting relevant regulatory exams, and then you translate them into a professional working and being regulated by relevant regulatory body.
Okay. So if we look at obviously what individuals, because we've talked about now 62,807, that's the number you gave from the time we started as 4 students to now this big number, being delivering health services at a personal capacity or at a greater capacity into the future, isn't it? So now we are saying that there is a huge chunk that has been delivered through those who've gone through a KMTC. They have. Now, a month ago, less than a month ago, we finally delivered, or at least launched, this universal health coverage, which looks at giving health services at the very basic level without you having to pay more than you would normally contribute. And so now here we are saying that if anybody has been primed to deliver UHC, it's the folks who've come through KMTC. So now, with what is being offered on a national level in terms of health and its services, would you say that KMTC today, as it is currently constituted then, is able to meet the needs that UHC is offering to meet?
Yes. I want to confidently say that KMTC has the capacity to meet human resource needs of the country. We have tailored our programs to address primary healthcare needs. And in primary healthcare needs, what we are looking at is the first point of contact for any individual with a healthcare system. And it means that it happens at the household level, at the community level. And then you want to ask yourself, what is it that a Kenyan who has not thought about going to the hospital need in terms of healthcare? First, they need information. So you have in KMTC a course on health promotion. They need information. They need to have certain things in place like sanitation, having a defecation-free environment. And so KMTC has a course on public health. And then you need proper nutrition at community level. We do not have to have malnourished children who are stunted in growth, or adults who have no proper nutrition. So we have in KMTC a course on nutrition. Then in order to galvanize the primary healthcare, you need people who can walk from house to house, monitoring cases, being able to do follow-ups. For example, pregnant mothers who are supposed to be delivering in hospital, having what we would call ANC visits, antenatal care visits. That should be at least 4. So you have these people with gadgets that they're able to remind a household mother that you need to be in the hospital on this date. That is where we have community health promoters. And we have, to galvanize all this, at least 100 households has to have someone who really makes sure that information flows correctly, that cases that are supposed to be reported are reported in a timely way. And that in KMTC now we have what is called community health assistants. So these people are able to interact with data, be able to process information that enables a household to make decisions about their healthcare needs. They also promote things like enabling households to access insurance, health insurance, that then is important for making sure that they do not suffer what is called catastrophic financial challenges. And that is the whole meaning of UHC, that all people are able to access quality health care wherever they are, whenever they are, without suffering catastrophic financial costs. And KMTC is geared in terms of human resources to provide solutions at that level. We also have what is called health information systems, being able to galvanize this information, collate it, organize it, making sure that each household, when you go to a health facility, you do not need papers anymore. So KMTC produces professionals who are called health records and information system professionals, who are able then to make sure that the system is flawless. You do not need paper, you do not need a card, you only need a system that is efficient. And KMTC produces professionals in this area. So we have tailored our courses in such a way that they are able to provide the primary healthcare needs of the country. And then as you move up the ladder of healthcare, then we have now specialized professionals in this area. And that's why we have curative, and then we have specialized courses at KMTC at higher diploma level to address what is called resource-constrained environment situations, where you do not have an anesthesiologist trained at the university. We have an anesthetist produced at KMTC who is able to work at that level 4 and provide care.
What's the difference between the two?
The level of practice.
That's it?
Yeah, the level of practice, yes.
Explain.
The level of practice, we have a highly specialized anesthesia, which can only be done in very high level hospitals like level 6 hospitals like Kenyatta, Moi Teaching and Referral Hospital, which require something like epidural anesthesia, which when you want to go through procedures like kidney surgeries, those levels of skilled anesthesia have to be provided by a more specialized, higher level individual. However, you have certain lower level of anesthesia that can be done at lower levels, like when you need to do diagnosis, like laparoscopy. Those kinds can be done by specialists trained at Kenya Medical Training College.
But at the university level, then you're trained essentially to be an anesthesiologist, but you're trained at the college to be an anesthetist.
Yes.
That's what we're saying.
Yes.
So then it's the level of education and training and not the level of practice. Because are we saying that if an individual goes to the training college and trains for this very same thing, and somebody goes to university level, by the time they come out, the person who is at the university level then is ready to go in and is allowed
a certain degree of practice that this other one is not.
Yes.
Right.
That's what you mean by the level of practice.
That's what you mean, not that the years in which you've actually been in theatre working it out.
All right. Level of practice, because in medical field there's a level of responsibility.
Okay. Yeah.
That if there's a suit, then it means that a person who is supposed to take responsibility should have the skills that match that level of practice.
Okay.
So as you go up the levels of practice, then higher responsibility is taken by the practitioner.
You know, I've often wondered, Daktari.
Yes.
What is the difference between a higher diploma and a degree?
Okay.
Okay, let me ask it from the first base. What is the difference between a diploma and a degree?
Okay. A diploma and a degree looks at various levels of competency. At a diploma level, basically you are training someone for skills majorly, and at degree you put more emphasis on the theory that then enables practice. So diploma takes a shorter period of time, that is in our case 3 years. In Kenya, degrees take up to 4 years. And so diploma level practitioners, majorly we concentrate on the skills of learners. So we have, in our case, 70% of our graduates taking most of the 70% of the time in the laboratories, skills labs, and hospital setup to be on the job in terms of their level of practice. When you look at higher diploma and degree, we have what is called KNQA, Kenya National Qualifications Authority. They do equation of degrees and diplomas. Now, there are certain levels of practice of diplomas, higher diplomas, that have been equated to degree, that is level 7 of practice of certain levels of diplomas, higher diplomas, to degrees through KNQA, so that they are able to then be able to practice at almost same level because of the equation that has been done by KNQA. We worked with them to look at then what's the number of hours that these people spend in class. Then what's the number of hours that they spend in clinical practice before they come back to do higher diploma. And then when they're doing higher diploma, what's the level of competency and the man hours? So then this then formed the basis of standardization in terms of level of practice and the skill and knowledge that the higher diploma has and degree has. However, there are certain degrees that still cannot be equated with higher diplomas, like pharmacy, like medicine, and like dentistry, because of the number of hours that the degree holder spends in class and they spend in clinical practice, and the depth that they go to before they graduate. So there are exceptions in classification and grading of diplomas, higher diplomas and degrees.
You see, as a layperson, one of the things that I took, and it was a misnomer on my part really, that when you talk to a clinical officer, you talk of a farm tech, you're talking of more of an adjunct of someone who has perhaps a higher qualification. And yet, in later years, I came to understand these are actually different professions. A lab tech is a lab tech. That's what they do. They're trained to be lab techs. Now, somebody who studied something like, say, microbiology or has a degree in the same, yes, they'll be in the lab, but what they do is similar in some ways, but again, as you say, competence is different. And the roles even that they play is different. And
even the decisions that they'll make,
yes,
on behalf of to the patient are different, because in medical field it is very clear, it should be very clear that the level of training should determine the level of practice and the level of responsibility that the professional takes for the decisions they make. And so that's why you do not take medical training for granted, and therefore when we design courses at Kenya Medical Training College, the first thing we really have to take care of is patient safety, and that the decisions that this professional is going to make at their level is going to assure the patient that they are safe in the hands of that professional at that level. Yes. Where it is beyond their scope, then the health system has a way of a referral system, that there are certain levels of practice, that certain levels of equipment and facilities that are arranged in levels, so that a referral takes place from a lower level to a higher level. But when people start to recuperate, then referrals can actually take place from higher levels to lower levels, because now the patient is recovering, and all that is needed is care for that patient to recuperate. And so levels of practice, levels of education determine the decisions that are made about a patient at various levels.
Sure.
So, since our topic of discussion is UHC, then does it not stand to reason that perhaps the focus on our training ought to be people who have these technical capabilities and who perhaps are able to work at the lower levels of healthcare facilities? Because that is where the majority of people actually ought to be, and that's probably where their healthcare needs ought to be taken care of.
City, you are very correct. Very, very, very correct. That if you focus at lower levels, that is primary healthcare level, you're able to save so much in terms of healthcare costs as you go higher. That means that if you put 1 shilling at primary care level, you are saving 9 shillings when you are looking at higher levels of practice, when now you are seeking treatment. And in KMTC, we actually focus so much on skill, that the people we produce are hands-on individuals. They are not people who sit in office and give instructions. They are people who go to the ground. They are like the army. They're like the infantry in the army, the ones who are the ground soldiers, to make sure that the health system works. And in KMTC City, we focus on the skills that these people need to ensure that households live healthy lives. And so if you look at the portfolio of KMTC, the portfolio is designed in such a way that if investments are done by counties at lower level, by ensuring that human resources for health are adequate at lower level, then we will have lesser incidences, lesser cases at higher level. And we actually focus on ensuring that lower levels of healthcare work before we now start referrals, talking about cases of surgeries. Then information should have been given at lower levels about healthy living. Yes.
So then obviously the delivery of health is also leveled.
Yes, yes.
It is from level 1 to 6, then in terms of facilities. And so are we saying now that there would be greater emphasis on those who are coming out of KMTCs to deliver health at that level? Because we are saying that truly if you're taken care of with these issues that lower levels then can provide for, then you reduce the burden on the higher levels. So should that be where a lot of the emphasis for training then is?
Yes, yes. And I want to say, Ndu, that KMTC does not work in isolation. It really works with the counties. And then in the counties, we want to ask them, which cadre do you need most to take care of your primary level of healthcare? Right now, to start with, we have CHPs who have been given basic knowledge, tooled and empowered to provide care. We also have, as I have mentioned before, certain cadres at KMTC who have been trained specifically to make sure that people live healthy lives in the community. And I have mentioned nutritionists, public health, we've mentioned community health assistants. And so now what we are looking at is calibrating need per county and making sure that the KMTC trains as per the needs of these counties. Counties have different types of needs. You see, in Kenya, we have those rural counties.
Yeah.
We have counties that border the highways.
Yeah.
We have counties that have historically had certain kind of disease patterns.
Yeah.
So when you have a county that is along the highway, they are likely to be prone to cases of accidents. So they will need certain cadres more than those counties that are rural, that do not have highways and do not encounter road traffic accidents. And so for such counties, we will have to, if you look at the pattern of KMTC in terms of the campuses, you'll realize that, let's say, a county like Makueni has a campus like Makindu. That campus will most probably offer courses that are geared towards facing challenges that the highway is likely to have for the citizens that are living in that area, like emergency medical technicians course for emergency response, just in case of emergencies.
So the Makindu campus will have more students who are geared towards this, more than even the Wote campus, which is in the same county.
Yeah. We will have, for example, orthopedic trauma medicine at Makindu, so that because those hospitals in those regions will register higher levels of accidents compared to counties where we do not have so much traffic, we do not have so much. So we will have that kind of pattern in terms of county needs and the training that we offer at KMTC. And we will also make sure that there are certain courses that are cutting across, like nursing, clinical medicine. Those ones will be like common denominators for most campuses. Then there are those courses that are geared towards primary healthcare that are really, really needed. We will try to make sure that they are at least in each county, like community health assistants, the ones that then coordinate primary healthcare to link to higher levels of healthcare. So our pattern of courses in campuses is geared towards addressing local needs of counties at that point in time.
Okay.
Yes.
You've talked about a 5-year strategic plan.
Yes.
That's when does it begin? When does it end?
It begins this year, ends in 2028.
Okay.
Yes.
So this strategic plan, by the time you're finalizing it, with the implementation of it, are we going to have a different outlook of KMTC? Should we expect something that's different from the previous 5 years? What are we going to see in the next 5 years?
It's going to be highly transformative. It's going to be define the competition in healthcare training in the next 5 years. First, we are looking at the quality of training. We want to ensure that in this key result area, we address the emerging issues. The current emerging issue is that after COVID-19, lessons were learned that the world is not sitting pretty in terms of the amount of health workers at every facility when you need them. For example, you had the developed countries struggling to keep up with the pandemic. And it exposed the underbelly of the healthcare system, the soft underbelly of the healthcare system when it comes to the most important pillar, that is human resources for health. So we then thought that in this new strategy, we should focus on not only ensuring that the country has sufficient numbers in terms of human resources for health that are relevant to the healthcare needs of the country, but we are able to produce graduates who are able to work in other parts of the world. So in the vision for this strategic plan, we are looking at a globally competitive institution for training human resources for health. And in the quality of training, to make sure that this is achieved, then we have to redefine what is called fit for purpose health workers. A fit for purpose health worker should be able to communicate, should be able to have requisite skills, and should be able to give quality healthcare. So in terms of communication, we realize that if we are going to produce human resources for health that are not only going to be relevant to this country but throughout the world, then we must make sure that they have certain skills of communication. They're able to speak various languages. So KMTC in this strategic plan, in the quality of training, is offering beyond what a medical professional should know. That is tailoring courses that at their own time, it is like an elective to make sure that they learn French, they learn German, learn Arabic, and be able to be prepared to sit for exams like English language tests. And we offer, we have a test center, we have a language center. So these are the new features of the new strategy that is outward looking, that is not only trying to address the healthcare needs of the country, but be able to have healthcare workers that can work in other parts of the country, and that healthcare worker will not be disillusioned when they graduate because the economy cannot absorb all of them at the same time. They have the choice of working in other parts of the world where a vacancy exists and they can have gainful living. We have another situation. Yes.
That means that you need to standardize the courses that you're offering at KMTC to make sure that they're globally competitive.
Yes.
That a diploma from KMTC can be recognized elsewhere.
Yes.
So what have you done about that?
First, we have what is called ISO certification. The institution is ISO certified. Secondly, we have collaborated with embassies. Like we now have a tripartite agreement between the country, that is Kenya, and UK. And we collaborate with British Council to provide the additional preparation that is needed for a nurse to work in UK. So they are prepared. They sit for an exam in an examination center that we also have. And when they leave the country to UK, they are ready to work. So all they go to do there is get a space to live, adjust to the environment, and immediately go into the work space, the work environment. So we are also trying to ensure that we have the exam that is being offered for entry for US, Canada, being done here in Kenya, to ensure that our graduates do not have to go to South Africa or India, because not every graduate will have those resources. So we have worked with the examining body to ensure that we have the process taking place here in Kenya. So we will now have to look at, before they sit for that exam, what else is needed. And then we offer it, prepare the students, they sit for that exam, and then link with other players to make sure that these graduates enter the marketplace there. So we are going an extra mile. We will not be satisfied to say we have graduated this number, but we will want to say we have graduated this number, and this number,
and they are working,
have gotten placement in terms of employment in this country, in this country, in this country, and the rest the country is able to employ locally. So that is the kind of key result area number one. We also looking at the issue of, in terms of quality of training, we have those cadres, like what City was asking about. You have higher diploma. You have somebody who has practiced as a diploma graduate for 2 years, and they are not able to leave the workspace because the employer, maybe the county, does not have the numbers to replace them when they leave to come to KMTC for another 18 months to qualify with the higher diploma. Yet the facilities they have at the county, because what is most important in diploma programs is the competency,
so 70%,
the capacity to do what they are supposed to do. So this person should be able to be trained at the local level. It's called collegiate training. So the higher diploma, if you want to have a higher diploma, you do not have to seek permission to come to Nairobi, to come to a campus, to do it full time and leave your workspace and the employer does not have somebody to replace you. We must be able to offer solutions that are flexible for learners who are also employed, so that we do not have people stagnating in one job group forever because they have not been given leave to come and train. We do not have counties suffering from lack of skills because the people they can send to be trained, if they do so, then they suffer certain financial challenges. So we want to offer a solution that is a bit different from what we've been offering up to now. We want to be relevant to the situations that our learners will find themselves in. We are looking at the issue of digital transformation. The world is quickly moving towards the digital space, and as KMTC, we no longer want to think that we are safe in terms of being able to say that we are competing at local level. There is the issue of telemedicine. The technologies that are fastest in terms of change are in the medical field. So we want to make sure we have that level of industry, academia, collaboration with industry players, especially in technology heavy courses. And so we will not just be able to say that once you learn your content in class, then you are able to practice. We want to go to, let's say, GE and make sure that the new technology for diagnosis is being transfused into the minds of the learners when they're in class. So we would want to make sure that that level of relevance is inculcated in our graduates. By the time they graduate, they should not be strangers to
they should
the
not be going to start learning that technology in the facility.
Yes.
That's right.
So we would want to make them very familiar with telemedicine, be able to know how to use information and be able to use it relevantly and competently, and also with a lot of responsibility, because data protection for patients now is very key in an era where technology is taking
now is a short time. We are just about 30 seconds out of the show. I just want to ask the final question. To roll out this strategic plan 2023-2028, is there any capital outlay? Do you need more money?
Yes. The strategic plan for the 5 years will cost 86 billion Kenyan
over the
shillings.
5 years.
Yes, over the 5 years. What we can realize through our normal revenue streams is 53.6 billion, giving us almost 26 billion in terms of revenue deficit that can actually make sure the strategic plan works. So then we have a component in the strategic plan for purposes of ensuring that we raise that extra revenue outside the traditional revenue stream through sustainability, making sure we work with partners, we collaborate, we look into other sources of revenue generation like internally generated.
Sounds like you're confident you can raise the money.
We will.
That you need.
We will, because we work with partners. We don't work alone.
Okay.
And we will be able to make sure that we interest partners to work with us.
Dr. Thank you very much for joining us. Come again, so we talk about this in greater detail. Dr. Kelly Oluoch is the CEO of the Kenya Medical Training Colleges. He's been our guest. KMTC is gearing to be the one solution for UHC, not just in the country, but also for training our healthcare workers who can be globally competitive.